Before we get started, I want to share something that happened after we stopped recording this episode. Once the microphones were off, Ben and I kept talking for a few minutes, and the conversation shifted to something quieter and honestly harder. He talked about how difficult it was to put this case on display, to walk through a story where things didn't go as planned and where complications piled up, where the outcome wasn't the one he wanted for the patient or for himself. Ben's a very skilled surgeon, and he's still early in his career, and I could hear how much this case weighed on him, not just technically, but emotionally. One thing that's important to know about Operation FUBAR is that I don't see these cases ahead of time. I come into these conversations without slides, without a roadmap, so that my reactions and the discussion itself can be as spontaneous and genuine as possible. What you hear unfolding is real. It's not scripted. And when we stopped recording, what stayed with me was how important it was for him to talk about this case anyway. How acknowledging failure and complication and limitation isn't weakness. It's part of the work. And for many of us, it's also cathartic. I shared with him that when I was a young surgeon, I had a case that haunted me for years. A case I replayed over and over in my head, wondering what I missed, what I should have done differently. And I remember thinking at the time how isolating that felt. Like everyone else had it figured out and I was the only one carrying that weight. Hearing someone else say, "I'm struggling with this too," would have mattered more than I realized back then. And that's what this series is really about. Not perfect cases, not victory laps, but honesty and reflection and the shared experience of doing hard things in imperfect conditions. With that in mind, let's get into today's episode of Operation FUBAR. Hello and welcome to the AHF podcast. I'm your host, Joe Schwab. Welcome to episode 2 of Operation FUBAR, our series where experienced surgeons walk us through the cases that didn't follow the script, maybe didn't resolve cleanly, and didn't reward confidence with certainty. In this episode, we're joined by Ben Feibel, an adult hip and knee reconstruction specialist in Louisiana who's thoughtful, technically skilled, and most importantly for this series, honest about the emotional and professional weight of difficult cases. And before we get into it, what makes this type of conversation especially valuable isn't the anatomy or the implants, it's the mindset. The moment when a case stops being about what can be done and starts being about what needs to be done. It's that tension between persistence and restraint, between technical possibility and judgment. And at some point in every surgeon's career, someone says the words, "I bet you can't do that." And what follows can define years of decision-making. I won't give away any details here, but this is a story about judgment under pressure, the limits of reconstruction, and the courage it takes to acknowledge when the best outcome isn't only the one you initially set out to achieve. Ben, welcome to Operation FUBAR.
Glad to be here. Thank you.
Let's talk a little bit about your background and where you're at in your practice.
Yeah, so I did my medical training in Louisiana at LSU in Shreveport. Did my residency and my medical training there. Then I went to Southern Illinois University and did my adult reconstruction fellowship there with Gordon Allen and John Horberg, who I think you've had on before. And I've been in practice 3.5 years now. I'm the total joint surgeon, reconstruction guy, revision guy in our group, a multi-specialty group, but Shreveport's pretty small, so get a lot of complex cases.
And it sounds like you're going to be talking about one of those complex cases today. Is that right?
Very much so. When you guys reached out to me, I knew the exact case I was going to present to you guys. So,
Excellent. Well, without further ado, why don't we bring up your case?
so the title of the talk simply came from one of my sports partners who showed me an X-ray, and he claims that I kind of said, "Oh yeah, that we need to leave that alone." And then he came back to me and he said, "Man, I bet you can't fix that. You bet you can't do that." And so that's where this case kind of starts with this particular patient. So this is a DP. He's a 66-year-old male, history of hypertension, COPD, and smoking. Of note, as you can see in the X-rays, he was history of a Girdlestone procedure 3 years prior. The patient really was a poor historian, could not really give me a reason. The assumption was infection. He had had no prior arthroplasty prior to this. And the prior procedure was done via the posterolateral approach at the time. So there's just a AP hit there on that side. And you can see he's significantly shortened here. And so pre-op workup, obviously I did a CBC, CRP, and ESR, all of which were normal. I then subsequently did undergo intra-articular joint aspiration, which yielded no sign of infection. So my plan for this patient was a direct anterior approach. My plan was to do a frozen section and deposit plan for antibiotic spacer. And if negative, I was going to plan him for an augmented cup with a diaphyseal engaged and modular stem. And with his significant shortening, I did counsel the patient on possible needing for a femoral shortening osteotomy, although with it being a Girdlestone within 3 years, I did feel that I would be able to proceed and get him as much to length as possible. And so he obtained clearances from everybody. And so the original procedure, again, was on the 1st of December 2 years ago. And as you can see, he's still significantly shortened as far as hip center goes, but on the HANA table, soft tissues were very, very tight. When I say I had to use every trick I had, my reps were pulling significant traction to get this hip reduced. And so at the time, this is a 36 millimeter head. That is a cup with the augment already built in, a RAS cup, and that was a 19 millimeter body plus 0. And that was as tight as we could get him at the time. Surgery went well, minimal blood loss. He did great. And so I don't want to jump too quick. And so he was waiting on rehab placement, was up with therapy. The guy had been in a wheelchair since the last procedure, so 3 years. So the guy was up walking 100 feet, did well, went to stand up. Again, I'm not sure how it is all over the country with his given insurance. It took him a while to get approved for rehab. And then on day 7, he popped out.
And this was while still in the hospital?
He was waiting on rehab placement, yes, sir. And so, obviously, what I concluded was that he, was stretching the soft tissues out, his abductors, everything was beginning to stretch out. And so I said, okay, not ideal, but we took him back for revision surgery with plan to lengthen him, increase his offset, and try to get him restored to natural hip center and everything. So I took him to surgery, again, lengthened him out. At this point, I went to a 21 millimeter plus 21 millimeter body and a +8 head. So we were to lengthen him out some more. And again, still very, very tight, and was pleased with where we were. I mean, we're not perfect by any means, but we're getting there. And my hope was, this would be where he settled. And so he was discharged and came back on the 16th. So he's lasting about a week at this point. And he dislocated again. Again, I went to do mobility on that last case as well when I revised him, did his poor soft tissue envelope, and he dislocated again. Again, it's always happened when I was not on call, and typically happened on a weekend, as usual, as these go. And so I came in on a weekend and revised him yet again. This was him on 12/17. Again, you can see we're still continuing to increase his length. He has a 21 proximal body with a +20 body in there with a +3 head. So we're gaining length with our proximal body. without maxing out our head. So I was pleased there, knowing in the back of my mind, we are slowly approaching, our maximum with this type of stem.
And you're keeping the same distal diaphyseal fitting portion of the stem in, right?
Yeah, from case one, when I tell you that part of the case, that bit, the aphyseal stem bit and did not want to come out. I tried to take it out on the second case and the third case,
Oh wow.
and it was not wanting to come out. And I tried every trick next to an ETO. The guy, it was a lot of education for this guy. Uh, you know, being an anterior surgeon, we pride ourselves on dislocations, and this was my first dislocation I'd had, of course, and
Sounds like it was your first, second, and third.
it was exactly. And at this point, I was about a year and a half into practice, and so trying to explain to him the reasons why and those kind of things were difficult. And so again, this was on 12/17. He discharged, went to rehab, came back and saw me on the 4th of January in clinic. Still looked just like this was. Staples were removed. All was doing well. He was then transferred to home with home health and comes back on the 13th. This
Mm.
is what he looks like. And so, again, starting to get very concerned. At this point, he's not drained. The incision has healed well, despite, multiple surgeries in a very short time. And took him back. And this was on the 15th. And this was the most pleased I was with the entire of the process. I was like, okay, we've got him anatomic. We've restored his hip center. And I thought at this point, we've got him to the point where I feel this is where he wants to be. And I felt very confident at this point. He then followed me back up 2 more times. I saw him 10 days later, then subsequently 2 weeks later, was doing great. No troubles, was walking, not much, but walking some. This is still intra-op here. And this was immediate post-op right here from
Okay.
that last case there. And again, pretty tight. I was pleased with where we were. Thought finally we were able to get him restored. And again, of note, this last procedure, he was at a 23 proximal body that was plus 30 and a plus 8 head. So I've now maxed out
Yeah.
everything that I had as far as proximal body goes.
And is this the same cup that you put in the first procedure?
Yes, cup has been
Yeah.
great. Cup
Yeah.
was the easiest part of the whole case. And so
Mhm.
it went nothing issue there. And so because if I went back, you could see because he had some changes proximally and superiorly in that his native hip socket, that's why I went with this augment. And I'll talk about it in a minute. I think that part of it was the difficulty in the reduction going forwards. And then he comes back on the 21st
Mm.
of February, and the wound's now draining, serious drainage. Labs are elevated, but he did have recent surgery. At this point, we had to have a tough conversation. The patient states he was tired of having surgery, didn't want anything else done, but they wanted this, whatever we did going further, to be the last thing. And I discussed with him in great length. I said, I can't guarantee that, I'll be able to guarantee him no dislocations. I can't guarantee anything. At this point, the soft tissue envelope around the hip was becoming more tenuous with every time I went in there.
Mhm.
And so after a lengthy discussion, we made the decision to basically restore him back to what he had. So I basically took everything out, and he still currently sits with a Girdlestone procedure. I was able to subsequently get him back, get all the implants out, and we cleared the infection, antibiotic beads, those kind of things. And so currently the patient's back to where we started. It was a big learning case for me.
Mhm.
Um, of course, me being the young gung ho surgeon, I wanted to keep going and see if I could, restore him and get him back, whether it's ego, whether it's, me wanting the best for my patients or a combination of both. That was the issue. Followed him up several times. We discussed, where we were, and he was fine going back to how he was, just with another incision. Again, difficult for me to do
Yeah.
in my particular practice and how I was trained, but it was a big learning curve. Basically, I was unable to appropriately, I guess, make the assumption of how much his soft tissues were going to stretch out. And with that slow stretching out of his abductors and all the tissues, of course, there was quite a bit of scar excision on the index case,
Hmm.
and then subsequently thereafter. The second thing was because he did walk, but he spent a lot of time in his wheelchair, he stayed in a kind of an axially rotated position. I even had him in a
Hmm.
hip orthosis after the final procedure, which I've not had to do before or after since that time with an anterior approach, trying to keep him from doing that. And the only thing I can think of, the way he was sitting was constantly levering on that proximal body because on the last procedure when I did explanting, that the stem, the proximal body was still had some micro motion in there, and I could never ascertain, and you know I'll call it the warrior in me or whatever wanted to keep going and try to get it better, but the patient just said, "Man, I can't keep doing this," and I said, "I understand." And so we cleared his infection, and he's back where we started. So we basically did 4 surgeries and did not necessarily make him better.
Well, let's talk about this a little bit because I have a few questions, and I want to start off with some of the technical aspects of this from your perspective.
Sure.
So you showed us a nice a set of plain radiographs, kind of documenting everything that happened to him. Did he get any additional advanced imaging when some of the complications started occurring, or was it something that you felt comfortable evaluating intraoperatively?
I did get a preoperative CT just to evaluate his. I wanted to really get a better look at his cup because I was actually as much worried about the socket as I was the femoral stem because just with him sitting out with the Girdlestone, rubbing, on that supralional aspect, I wanted to make sure I had enough bone stock, which I did. I mean, I had cut cages there. I had, everything at our disposal if needed and didn't need it. I wanted to bring his hip center back to native in the socket because I knew with that cup I could do that. And so that's where I
Hmm.
started. And then, yeah, I believe that case between 2 and 3, I did CT scanning just to make sure nothing was being missed. Was there a breach? Was there a fracture? None of those things were there. Um, and so, yeah, I did get CT before the index procedure and then in between case 2 and 3.
And no concern about cup anaversion, cup inclination, anything like that, based on the CT between 2 and 3.
No, I did use the Mako robot for the cup, and
Okay.
And, I did make a few changes here and there, and I was very pleased with my cut placement. I tend to on these, I don't abide by the 40-20 rule, with that 100%. I may under invert a little bit with that known problem,
Hmm.
with that, and I think he was probably 40-15 if I remember correctly, is what I put him at.
So you were using Mako for this, or you were using robotic navigation, some sort of. It sounds like
For the index case, yes, sir, I
for
did.
the index case, and
Yeah.
that's what you're doing for most of your primary total hips. Is that correct?
Most yeah, probably 70-80%, yes, sir.
And in this particular case, was there a reason that it didn't fall in the 20 to 30% that you don't use it? Is this a case that you would specifically indicate using robotics for, or what was the thought process there?
Because I use it a lot at the given hospital I was using it and that my workflow with my team, I felt that it was appropriate. I was dealing with so much scar. I was concerned too about using, doing a manual cup about, being able to, I don't want to say give it a C, but taking down so much soft tissue for a manual cup with the robot with me able to dial anything in. I felt it was advantageous to do that. So,
Yeah. And so, a
yeah,
couple of questions as a sort of as a young surgeon who's taking on a
sure.
complicated case, wants to feel, you kind of talked about the warrior attitude and things like that, and you want to be out there proving yourself and taking on the hard cases. Um,
Sure.
when you get to not the first revision, which one could maybe even anticipate, right, that this is going to be a complicated follow up story, but when you get to the second revision, do you start thinking any differently, or walk me through your sort of mental process as the we'll say complications continue piling up?
Yeah. So I'm the only, in my group, I'm the only interior based surgeon. As far as workflow and plan, you know, I, I, my older partner agreed. He said, "I think that, you're doing the right thing. I think he's continuing to stretch out." And again, the frustrating part for me was, although it took, 4 procedures to get there, I finally thought that I'd gotten him right where I wanted him. And that was
Yeah.
the part that was the most humbling and frustrating at the same time, was that. Yeah. And so at that point, I think I would have, number one, probably asked for more help versus, I don't transfer stuff out. I want to train that way. But I was to the point, and the patient kind of made that decision that he was done and tired of doing it. And so that was the frustrating part. I
Yeah.
understand his wishes and I respected it, but that was the difficult part. So
Well, and let's talk a little bit too about, when you get to that point with the patient where you've got a plan for, now we're on step 4, we're on step 5, we're on step 6, and you continue to have things in your arsenal. Um, how do you sort of structure a conversation with a patient where maybe you feel like there's still life left in what you want to do, and the patient is expressing concern about going forward for whatever reason?
yeah, I mean, the delineating factor, I think, for him and somewhat for me, was when he began to drain,
Mm,
with the concern for infection. Because when I explained to him the process in which, for him, I would have gone with a 2-stage, revision on him because of his, soft tissue envelope and the amount of procedures we had done. I When I explained those things, he finally said, Doc, I'm done." And I
mm.
said, "I respect that." And I kind of told him, I said, "We're basically going to put you back just like you were, as long as you understand that." And I think that was the only, I guess, positive thing, is it wasn't like you were taking someone that was somewhat ambulatory and who was functional, um, and you're putting him right back where he was, opposed to him if he had had a native hip in and he had gone down this road. I guess that was somewhat helpful, and that was what he said himself, is like, "Doc, I'll just go back like I was. That's okay." Um, Although very tough, that was a hard pill for me to swallow, to be quite frank.
And so when that next Girdlestone comes into your office, how are you going to approach it? What are you going to do differently? How are you going to counsel the patient, and how does this look the next time around?
Yeah, and I've had several others since then, and they've done okay. They've done great. And, one procedure, and and they're over a year out, and I haven't had trouble and so far. And so I think it's just, you just learn what's just about one of the worst things that could happen with these multiple surgeries in such a short time. It'd be different if it was, 3 or 4 months at a time. I could almost stomach that a little bit better. But as far as it being such a close time frame, the index case was 12/1, but the final case, on, 12/22/21. So over a 3-month period,
Yeah.
you had all these surgeries, and that was the part that was difficult. I think it's just counseling patients, knowing what could happen. I think in the South, at least, referencing not people by name, but referencing, "Hey, I've had this case before. This is what happened." And I'm a very candid, open person. I don't paint I paint a real picture for people, not so much I don't want to, give them too much hope, but I want them to understand the reality.
How much do you think the original reason for his Girdlestone came into play in this case? That's such a unknown area. Were there aspects of that you think were contributing, or not so much?
I think it's a little bit of both. I think, I was trying to find out, Louisiana is not a very large, it's a pretty good tight knit community of orthopedists. And so I knew it was done 2 hours south of us. And he thought he knew who had done it, and actually reached out to that guy and kind of discussed, looked through all the EMRs, trying to find some reason. And, the guy that I spoke to didn't even remember the case, to be quite frank with you. Um, and so I said, "Okay." And so I think that was one. 2, I think, having to do with his, um, how his positioning and how he's set. I think the man sat with his leg airplane rotated at all times, shortened. That definitely didn't help. He wasn't as much of a, he wasn't, I've seen Girdlestones to be a lot more functional than he was pre-op, and I do think that played a role as well. So
In your pre-op, that actually raises another question. So, in your preoperative imaging, when you CT'd, were you able to assess some of the quality of the surrounding musculature, the abductors, the short external rotators?
a little bit, yes. I mean, you can see somewhat. I mean, he still had abductors. But when I delivered the femur during the procedure, I mean, um, you know, there was plenty of abductor there at the time of surgery. Going into it, um, I'm obviously not anti mobility, as you can see, but at the time, I mean, because I stress all these intra-op, I have my own little, algorithm of stressing, for stability, and he passed all of them. That was another frustrating part.
Yeah.
I brought him to 9 degrees and bone hooked him straight, vertical, and could not, without any traction, could not dislocate the hip. And so, there was a lot of soft tissue in the prior girdlestone bed and along the shoulder of the femur that, I had to take down, but it didn't seem to be, it was all, scar more than anything else.
Mm. So you've touched on this a little bit, but the other question I have for you is really about the patient's perspective at the end. And you said the patient obviously didn't want any further surgery, seemed to be okay with going back to his, sort of essentially his initial state. And the question I would have
Yeah.
for you is, did you get the impression that he was happy that you tried, or was he upset at the result? And maybe you have some insight into that, or maybe you don't.
Oh, I do. I will say I felt like I did a good job at before the index case of painting the picture of what could happen. And he told me, he said, "Doc, I want you to try it." And
Mm.
and knowing that in the back of my head that he said that was helpful. And that I actually referenced that conversation when you had the explant conversation. And he said, "Doc, we tried," and he was not upset. I mean, I think I would have been. And at the same per as a patient, knowing what I know, I would have been upset. But at the same time, he said, "Doc, I've been this way for 3 years." And so, oddly enough, and I've seen him subsequently since then, intermittently for different things. And um, he's got a, he's okay. And so I do have insight there. But I think having that conversation, documenting that conversation well on the onset, I think was a big thing.
Does his response, or maybe his, we'll say for lack of a better term, his satisfaction with what you tried to do for him, is that surprising to you, or is it something you would expect, or how do you think about that?
I mean, that's twofold. I mean, with him being okay with it despite all the procedures, number one. Number two, state of Louisiana, he didn't sue me. That's nice too. Which was good. Uh, but at the same time, it was surprising. I was not prepared for it. What he came to me when I saw him that last time before the last procedure, and he said, I just can't keep doing this. And I said, I understand. And I said, I just wanted him to make sure he understood that I'm not going to ever get you back to walking, which the other frustrating factor was the guy got up and walked. I mean, he walked, I want to say I looked at the PT notes, yesterday when I was reviewing for this, and I mean, he walked 150, 200 feet, like
Wow.
day 2 or 3 after his first surgery. And so that was the other part that was hard for me as a physician and a surgeon was we did it. We got him. My joke was we got him vertical and got him walking, and then to lose that was harder for me, I think, than it was for him.
Interesting. Interesting.
Yeah,
Um,
yeah,
so you do still get to see him occasionally, it sounds like, for other issues. Is that right?
yeah. I mean, I think I've injected his shoulder a time or two, and that same partner that told me that he did a reverse total shoulder on him, and it's actually dislocated several times, and he's a very good surgeon, and he hasn't had issues. So it's one of those things. It's kind of he's just one of those guys, and we take care of him when he needs us, but he was doing okay.
My goodness. Well, I'm sure
Yeah.
I'm sure he's thankful to have a group of surgeons who are looking after him. But it sounds like he's one of those albatrosses that can hang around a surgeon's neck for a long period of time.
Yeah, I'm not upset it wasn't in my blood collection period.
Um, well, Ben, I really appreciate you sharing this case. And the next time somebody tells you, "I bet you can't do that," are you going to be thinking about this case?
Oh, 100%. And I will, and not just with this kind of particular case, but any case that's, that has been said to me, going forward since that time, I'll never forget it. So,
Well, thank you for sharing this case. Thank you for sharing it with our listeners, and thank you for being on Operation FUBAR on the AHF podcast.
no, thank you guys so much for having me.
Thank you for joining me for this episode of the AHF podcast. You can find the AHF podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube /@Anterior Hip Foundation, all one word. Episodes of the AHF podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips happy, healthy, and maybe free of girdlestones?